Hello, everyone, and welcome to today's webinar, Neurodegenerative Disease Biomarkers. What can they tell us about FTD? My name is Esther Kane, and I am the Director of Support and Education at the Association for Frontotemporal Degeneration. Thank you for joining us today. We are pleased to present today's program designed to educate health professionals and neurodegenerative disease biomarkers. Dementia diagnosis and treatment have advanced quickly over the past few years. The development and use of amyloid and tau PET, as well as FDA-approved blood-based biomarker tests, means that more people with dementia are being tested for biomarkers. This enables more amyloid-positive individuals to choose whether to access approved Alzheimer's treatments early. At the same time, more individuals with dementia are confirmed to be amyloid negative, meaning that other neurodegenerative process may be the cause. This panel discussion with three physician experts in the dementia field will discuss the current state of neurodegenerative imaging and blood-based biomarkers. Just a few quick announcements. First, you should know that we have muted our audience to minimize background noise. AFTD staff are working behind the scenes, so if you encounter a technical issue, let us know directly by writing a message in the Q&A box. Second, time permitting, we will conduct a brief question and answer session at the end of the webinar. Use the same Q&A box to submit a question. If you want to submit a question anonymously, just click the box to the left of the send button. We will try to answer as many as we can. You don't have to wait until the end of the webinar. You can ask a question at any time. Also, this webinar will be recorded and archived for later viewing on AFTD's YouTube page and in the webinar section of our website. For some of you, you may be asking yourself, what is a biomarker? If this is you, join us next month for an introduction to FTD biomarkers, a session designed to take you back to the basics of biomarkers, designed especially for individuals and families with clear expectations. AFTD's website includes an entire section with FTD-specific information for healthcare professionals. This section includes our entire archive of healthcare professional webinars, as well as a library of the issues of our e-publication, Partners in FTD Care, which details best practices and other information to support your work with families. New issues come out every other month. You can get them delivered by email by joining our mailing list. Next, the FTD Disorders Registry is a powerful tool in the movement to advance the science, discover treatments, and a cure for FTD. We encourage anyone with a connection to FTD and an interest in research to join the registry and help change the course of these disorders. Participants can share their lived experience and remain informed of FTD research opportunities. Visit ftdregistry.org to learn more. For healthcare professionals watching today's webinar live, we are offering continuing education credit via Rush University. This is part of AFTD's efforts to educate healthcare professionals on FTD and FTD care. Tuesday, February 17th, you will receive an email explaining how to apply for your credit. Be sure to check your spam folder. You have 6 days from the receipt of the credit email to complete the evaluation and claim credit. For today's webinar, we have 4 learning objectives. To describe the current state of neurodegenerative biomarkers and their role as part of a comprehensive differential dementia diagnosis. Identify the emerging role of p-tau, NFL, and GFAP in identifying specific types of neurodegeneration. Describe how neurodegenerative biomarker advancement is driving early diagnosis for non-Alzheimer's dementias, and recognize the critical role various healthcare providers play in the diagnostic process for patients with non-Alzheimer's dementia or a complicated symptomology. Additionally, you will receive a follow-up email next week with the recording of today's presentation and other related materials. AFTD also wants you to know that AFTD and the FTD research community are committed to discovering biomarkers for FTD. AFTD has invested over $12.9 million to biomarker-funded projects. Our 2025-2028 strategic plan prioritized diagnosis and treatment with biomarkers as a major focus. We have supported multiple biomarker programs and hosted major research events in 2023 and 2024. A special thank you to the Cy Newhouse Foundation, the Holloway Family Fund, the Alzheimer's Association, the Rainwater Charitable Foundation, the Robertson Foundation, and the Alzheimer's Drug Discovery Foundation for helping fund our biomarker programs. Now, I'd like to introduce our three expert panelists. Howard Rosen is the Dorothy Kirsten French Foundation Endowed Professor for Parkinsonism and other neurodegenerative disorders at the Wheel Institute for Neuroscience in UCSF's Department of Neurology. His research focuses on early and accurate diagnosis of dementia. He has used a variety of experimental approaches, in particular brain imaging. He is a lead investigator on several projects aimed at improving diagnosis, particularly for FTD. Dr. Rosen is also a key investigator in UCSF's Alzheimer's Disease Research Center and serves as Associate Director of UCSF's ADRC, leading the ADRC Imaging Core and co-leading the research education component. He also serves as the Director of UCSF's California State Alzheimer's Disease Center. Simone Ducharme is a neuropsychiatrist and a clinical scientist at the Douglas Mental Health University Institute and the Montreal Neurological Institute. He specializes in FTD and the intersection of psychiatric disorders and dementia. His research program uses advanced neuroimaging techniques and other tools to develop diagnostic biomarkers for FTD. Sammy Barmada is director of the Brain Bank and an associate director of the Medical Scientist Training Program at the University of Michigan. Combining basic biology with translational research and technology development, his research centers on critical abnormalities in RNA and protein metabolism in FTD and ALS. And now I would like to invite my panelists to the stage with me. Welcome, everyone. I'm so glad that we have this opportunity today to talk a little bit about these biomarkers and the FTD diagnostic process.
Hi, Esther. Hi, AFTD and AFTD friends.
This is a little bit of an informal conversation today, but I hope it's very informative for those of you who are watching to better understand what we can understand about FTD in this new landscape of emerging biomarkers in the neurodegenerative space. So FTD is a heterogeneous disease, and the current clinical criteria rely on symptom assessment and brain imaging that leads to delayed and often misdiagnosis. FTD is commonly misdiagnosed as Alzheimer's disease, psychiatric disorders, and our Parkinson's disease. So I wanted to ask our panelists, what are some of the challenges of the current FTD diagnostic criteria when applied to real-world patients that you're seeing?
Maybe I can jump in. I mean, as you described, so we use combination of symptoms, behavioral observation, clinical cognitive tests, and brain imaging, um, which over time allows us to make a diagnosis. But we face some challenges, particularly in the milder cases. So at some point, when someone progresses in their dementia, we will see what we call the atrophy, the brain shrinking, the PET scan will be abnormal. But when we see these milder cases of behavioral changes, sometimes we'll have ambiguous test results, which will lead to uncertainties about is it degenerative, FTD, is it psychiatric? There used to be challenges to differentiate from Alzheimer's. Now, as we will discuss, we have more biomarkers option that makes this distinction easier, but we're not quite there with FTD.
Thanks, Simone. I agree. I was thinking it might be worth stepping back for a second and just reminding us, everybody, what we're talking about with FTD. Um, it, uh, F, the terminology of FTD and related disorders has been confusing over the years. I think for me, the most useful way to think about it is there's a pathology in the brain called frontotemporal lobar degeneration. And that's different from Alzheimer's disease, different microscopic changes. And that could present in one of a variety of syndromes that each has different early symptoms and different symptoms over time. The and One can group all of them under FTD if you want, but just to have an idea, you have syndromes like progressive supranuclear palsy and corticobasal syndrome, which the predominant thing that makes them really different is movement dysfunction in the that looks somewhat like Parkinson's disease. Then you have the behavioral variant of frontotemporal dementia, which is the one that presents with social and emotional changes that sometimes can be confused with psychiatric disorders. And then you have the progressive aphasias. So the earliest symptoms really can be language, movement, or behavior, or cognition, even memory and sound like Alzheimer's early on. I think it's important that everybody should know everything all the progressive aphasias, the behavioral variant of FTD, progressive supranuclear palsy, corticobasal syndrome, each of those has published diagnostic criteria. And, it's worth looking at either a paper that kind of reviews those diagnostic criteria or a summary of them, just so you know that there could be a lot of different early symptoms that might represent FTD.
Yeah, that's helpful.
Yeah. And I guess I'll just add very quickly that I think the way that I view it is that there's a spectrum of symptoms, and the basic rule is that things like Alzheimer's disease that are very common can present in unusual ways. And now we have biomarkers that can distinguish Alzheimer's, but we don't have that for FTD. And so it's still a diagnosis of exclusion. We can knock a lot of things off of our list that make FTD more likely, but we still can't say, yes, this is FTD, unlike some of these other disorders like Parkinson's or Alzheimer's.
I forgot motor neuron disease, often called ALS or Lou Gehrig's disease. That's another clinical presentation of this pathology.
Yeah, which can be very confusing and which leads to a lot of the overwhelm that families face in actually getting an accurate diagnosis. We talk a lot about the importance of a good clinical assessment as part of the comprehensive diagnosis. What do you guys see as the emerging role of fluid and imaging biomarkers in improving diagnostic accuracy in light of the importance of good clinical assessment?
I
I,
think,
Go ahead. Oh,
go
I
for
was going to
it.
jump in
I
on
was
this.
going to say, yeah, you almost made the point, which is that it's important to communicate that, particularly in FTD, there's no diagnostic fluid biomarkers. So we are increasingly using some biomarkers to rule in, rule out various diseases, but they should always be used within the proper diagnostic context, which is following a clinical assessment. Because all these tests have limitations, they have false positive, false negative. So if you do not use them in a context where you have high probability of a disease being FTD or being Alzheimer's, you can have a lot of false positives. So it's very important to reinforce that even though we're having some new tests and tools which make our practice maybe more precise, we still always start by a very good clinical history with patient, with family, covering all the symptom domains that Howie was listing, and then we follow that with rational use of tests.
I agree with that. And what I was going to sort of say, Simone, which to frame things is, I think I think of the process of addressing cognitive and behavioral changes and motor changes in aging as starting with detection and then moving into assessment, right? And so detection really means some approach that, some people would call screening, where you're just, you know, listening for or asking some very simple questions. Is anything changing now that you're getting older that we should know about? So there are lots of different tools out there to kind of remind you. Even in the detection phase, people focus too much on memory and not enough on social and emotional changes and motor changes. And so I think, and language change, I think it's important to find a couple of questions that you would ask. Um, and I think asking questions is enough. I don't think you have to choose a cognitive screening tool. Um, I think the questions are more sensitive. So at that stage, all you've done is identify that something needs to be assessed. And I think at that point, you already have a choice of what to do. And I think I'm agreeing with Simone that the next thing you should do is not turn to a biomarker, but rather say, okay, we really need to sit down, have a conversation, and look for all of these symptoms, including a knowledgeable, informant or, collateral source to make sure that, you have an accurate history. And then you use the biomarker when you feel that you've established your differential diagnosis, thinking about all those features of the disorder that or the complaint.
Yeah, I also agree. I feel like it's one way to think about this is in relation to other commonly used biomarkers or tests out there like troponins or D-dimers. We don't interpret them in isolation, right? You interpret them within the clinical context. And whether, you're doing a general physical exam and listening to their heart, or you're doing a detailed cognitive examination, I feel like there are a lot of overlaps, right? You can't look at one test and its results without taking into account the presentation.
Yeah, that's really, really helpful. So we know that biomarkers are coming out now, right? There's the new blood-based biomarker for Alzheimer's disease, which is now FDA approved. How do you guys see the biomarker advancements in other diseases, such as Alzheimer's or ALS, driving more accurate diagnosis in FTD? Do you even see it driving more accurate diagnosis for FTD? Because I think it's fair to ask the question.
Yeah. The main biomarker, well, just to be clear, there's a number of biomarkers for neurodegeneration, and the ones that relate, there are some that just tell us that something is wrong in the brain, like neurofilament light chain, which can be abnormal in multiple sclerosis or after head injury or lots of other contexts. And Sammy and Simone may add to that, but it just tells us something's wrong and that there might be injury to the brain of various kinds. And so similarly, you would interpret that in context. And then there are biomarkers which are designed to detect the specific, what we believe is the pathological protein that is altered and likely, we think, the cause of the degeneration. So, for example, in Parkinson's, the protein we're talking about is alpha-synuclein. In Alzheimer's, the proteins we're talking about are A beta, which accumulates in amyloid plaques, and tau, which accumulates in tangles. So, for Alzheimer's disease, we now have several ways of detecting those proteins. We have amyloid PET, we have tau PET, we have blood tests that detect abnormal phosphorylated tau in the blood. That's why they're blood tests. And we can detect also the A beta 42 level changes and phosphorylated tau changes in the cerebrospinal fluid. So there's a lot of options. And so to answer your question, Esther, the deepest, toolkit for identifying these abnormal proteins is in the Alzheimer's space. So um, if somebody presents with complaints that are even remotely similar to Alzheimer's disease, and you decide I want to pursue Alzheimer's biomarkers, and you think there's a neurodegenerative disorder happening and they're negative, then you already are starting to think of FTLD, that spectrum of pathology, as one of the possible causes. In those younger than age 60, 65, FTLD related disorder is probably the most likely cause of a neurodegenerative disorder if it's not Alzheimer's. They're about even, depending on the specific age group in the younger ages. Even in older people, FTLD is much less common relative to Alzheimer's and Parkinsonian disorders like regular Parkinson's disease and Lewy body disease. But it's still prominent, and it becomes much more prominent if those biomarkers for Alzheimer's are negative. Um, probably the last thing I'll say, which I know we're all thinking, is the other thing you need to know is that lots of people can have co-pathology where you have more than one neurodegenerative protein accumulating and causing symptoms. So just if something really sounds like frontotemporal FTD and the Alzheimer's biomarkers are positive, you have to bear in mind that there could be FTD and Alzheimer's there. And that's a nuance. It's something real experts who think about this all the time can help figure out. Um, but it's been my experience that when it sounds like there's FTD involved, it's often true, even if the Alzheimer's disease biomarkers are positive.
Simone and Sammy, do you have any additional thoughts?
I can add, I mean, in my context, the emergence of the blood biomarkers is helping because of how easily accessible it is. We've had biomarkers from lumbar punctures and various forms of specialized PET scans to rule out Alzheimer's disease for many years, but they were more challenging to obtain. And so this would vary from setting to setting. There's some big academic centers that might be able to do this in most patients, but as soon as you go out in other areas or other countries, these are not biomarkers that were readily obtained on all patients. Whereas now that we're moving toward blood screens, which are maybe not perfect but are very good, then it is increasingly feasible to do that in most patients. So you're moving toward a practice where you're really more focusing on pathology and being more precise, particularly for the Alzheimer's versus other degenerative categories.
Yeah, and I guess I just had three quick points to add to those. I think that the use of these biomarkers is in general sort of lowering the threshold and sort of increasing the referrals and people thinking about things that are not Alzheimer's disease or something more common, right? Whereas before we might have just lumped it under that. So I think in that respect, we are thinking more about FTD and maybe we'll diagnose it earlier. Secondly, I think in some ways the biomarker identification and other conditions like ALS is going to directly spill over into FTD because some of those same, as Howie mentioned, there's a lot of overlap between FTD and well, at least a portion of FTD and ALS. And so we may see some of those same biomarkers being very useful for the diagnosis of FTD. And then third, on a more practical and maybe not as optimistic viewpoint, I think that even there are co-pathologies, and I completely agree that when there is the presence of Alzheimer's doesn't necessarily mean there is not frontotemporal lobar degeneration. The problem is that now we have treatment options available for Alzheimer's, but not FTD. And so it will get minimalized because from a physician standpoint, we focus on the like what we can do. And what we can do is treat the Alzheimer's that is there. And I sincerely hope, I think we're all in the camp that that will change. But unfortunately, that's where we are right now.
And I think for a family or a person diagnosed, if it is Alzheimer's that they want to treat the Alzheimer's, it's good for them to know
Yeah,
that. And
I
so,
mean, we do what we can, right?
yeah.
Yeah.
So talking about that and talking about p-tau and the way that p-tau is being used, what would you want the audience to really know about p-tau in context of FTD that maybe you haven't already discussed?
So
It's p-tau,
uh,
right? Not p-tau.
p-tau meaning phosphorylated tau,
Yeah.
just so people know, which is the form that accumulates in neurodegenerative diseases like Alzheimer's. And somebody asked, Nicole asked, what is the percentage of false positives? So we might as well address that along the way. And it's tricky. I would say we don't know yet. So most of what we know about phosphorylated tau in the blood, for example, is from very curated research environments where we bring people in and we study them very carefully. Often that means that a lot of other illnesses, there are people who don't have a lot of other comorbidities, making it difficult for them to participate in research. So they're not completely representative of the whole population. In that context, these, blood biomarkers for Alzheimer's disease, the phosphorylated tau, look very good in the 90 plus percent sensitivity and specificity. And the gold standard is an amyloid PET scan for most of those studies. There are some autopsy confirmations too, but so in that context, very good. I think we're just at the phase now in the last kind of year and going forward where we're going to start using it in a wider variety of people in the community with more comorbidities and lots of other clinical variation. And I think we'll learn more about the true sensitivity and specificity there. I think for that reason, we don't consider that phosphorylated tau in the blood a gold standard or the only test we should make regarding diagnosis and treatment. Uh, so if I would say if one has a if something is positive, like the phosphorylated tau level is elevated, and you want to make treatment decisions on that, you would go for an amyloid PET or a spinal tap. They're both considered gold standards for that. And if you have an extremely strong suspicion based on the clinical presentation, even if that phosphorylated tau is low, and you think, boy, I feel like this is a real Alzheimer's kind of story, and I wouldn't want this patient to miss the opportunity for treatment, I would order an amyloid PET or get a spinal tap anyway, given what we currently know. But on the other hand, if you sort of, it's not such a strong suspicion, and you say, I just want to make sure, I think that's a more reasonable way to just get the phosphorylated tau in the blood and call it quits at that point. Or if you don't think there's big treatment decisions that you're going to make, but you just want to make sure that you think you have the right diagnosis, I think phosphorylated tau, I would try, that's how I use it.
Yeah, I would come back to the clinical context. So you see patients where the clinical story perfectly fits early stages of Alzheimer's. Their cognitive test fits that. Maybe they had an FDG PET scan, which is another test we use that's a bit more non-specific, but has some signature strongly suggestive of Alzheimer's. And then you add on that your blood biomarker, your p-tau 217 is extremely elevated. You can pretty much be certain you have the right thing. But um, it's very important to understand that the performance on tests depends on the population you're using it on. So if you want to start using, as we're starting to see people using p-tau 217 more as screening tool in less selected population, well, this small false positive rates will turn out in a lot of people with false positive biomarkers because your pre-selection is insufficient.
Hmm.
Yeah, I I totally agree. I think that just as mentioned before, these are what we know about these tests primarily comes from the research realm, and we're still learning more. And this is where, we need that information in the real world. It turns out that people with ALS also have elevated p-tau, right? So that we don't think that they have Alzheimer's, but we think it comes from the disease. So there are sources, there's probably false positives, and we need to learn more about those. The second thing is that even in these studies, there's a cutoff value for normal versus abnormal, but there's a whole range of values even within the normal group. And it's worth keeping that in mind whenever you get a test back. I think a low level is very useful in terms of its negative predictive value. But I don't think it's ready as a screening tool yet.
Yeah. You guys have my mind spinning right now. I can only imagine the audience is thinking the same way, and in positive ways, though, right? We need to think about this a little bit more deeply. And I think a lot about the patient's experience in getting a diagnosis, and very often it's hard for them when you have active disease to continue to go back and to the doctors for more screening, to get the PET scans, to get the MRIs, to even sometimes get to go get the blood work done. And so that's something else to be mindful of within the process is that sometimes the cooperation of the patient to do all of these diagnostic tests within FTD can be extremely difficult. And it's just something we hear a lot from families in the process. But that being said, another biomarker we've heard a lot about is NFL, specifically in the FTD space. It was used a lot in some of the recent clinical trials. Many of the families are aware of it as a term, but we know that NFL is very nuanced. And so, can we talk a little bit about NFL and what does it not tell us about what's happening in the brain?
Let's
Sammy,
see.
you want to go?
Yeah,
Yeah,
you
sure.
go.
I'll go first on that one. I think, it's really useful to think of NFL as a protein that comes from neurons, the cells of your brain. And pretty much anything that affects those neurons is going to cause an increase in NFL. You could probably cross your legs and end up with a perineal neuropathy and have an elevated NFL. Of course, the levels of a persistent, progressive neurodegenerative disease, the neuronal damage that you see, you're going to see higher NFL levels, but it's a very non-specific indicator of neuronal damage. And that is how we're using it. And so it's very useful. It's sensitive. It'll tell you that there is a problem with your neurons, but it is not specific.
Hmm.
I also think that the same caveat about that we know about it from research and how well it behaves, but as we use it in a wider variety of patients, its true, sensitivity and specificity will probably still emerge.
So one of the interesting news, to come back to your first question, was to differentiate it FTD or other neurodegenerative diseases from idiopathic psychiatric illnesses. We're talking major depression, bipolar disorder, and others. Where in research cohorts, it does reasonably well. It's not a perfect accuracy, it's in the 80-85% accuracy. But these are in well-characterized cohorts. So we're starting to integrate that clinically. So it is useful, but there's a lot of gray zone in results. And there are definitely some false positive, false negative. In patient with psychiatric disorders, on average, we do see some slight elevation of NFL. So one word of caution is that, to conclude someone has a degenerative disease, the level should be really high, like several times normal, not just marginally above the thresholds. And also, NFL is a marker of the velocity of neurodegeneration, so the active process. So if you have a stroke, it will go up, but it will eventually go down. And so in some of the more slower progressive form of FTD, NFLs will not necessarily be very high. So it is emerging as a useful test, but there's a lot of caveats and potential pitfalls with NFL. It's also to reiterate, it's not a test that has any specificity for any of the pathologies in the brain of FTD. It's really a non-specific marker of any form of brain degeneration and other condition, as Sammy was mentioning.
And to complicate things further, we talk about the degree of NFL elevation, but it depends on how you measure it. And different platforms, different places measure it differently. Right. So what is high really depends on who's measuring it. It's so not as black and white as it's made out to be.
And it probably needs to be controlled for a few factors. The big one is age. So NFL increases slowly with age. So norms have to be adjusted based on age. And in one of the study we did, we showed that the accuracy was much better in the younger patient than in the older patients because of that. It can also be influenced by kidney function, but BMI. So it's an intriguing test, but it's a bit of a dirtier test for clinical interpretation.
Yeah. Thank you. That was actually very helpful, and hopefully it's helpful for the clinicians and the families out there too. I'm hearing more and more from you guys that even with a positive test, you really have to look at the sensitivity, and the amount of increase is really important to understanding what you're thinking about in that process. So another one that we hear about from time to time, not as commonly, is this GFAP as a test to measure neurodegeneration. What are your thoughts on GFAP, and if that's, you know, worthwhile pursuing or
I guess I can start with this one too. So GFAP or GFAP is glial fibrillary acidic protein. So it comes from the glia in the brain, these supporting cells, and generally it's sort of we think of as a marker of inflammation in the brain or neuroinflammation because the glia in the brain are in large part responsible for that inflammatory response. And one way to think about this is the inflammation that occurs is it happens around the same time as the neuronal damage. We tend to think of it as a secondary response to a problem in the brain, right? And again, like the NFL, a lot of things can give you inflammation in the brain, right? Multiple sclerosis, neurodegenerative disease, brain injury. So there's so many things that can cause elevated GFAP. And a lot of times it goes along with the NFL. It doesn't have to. It depends on how intense that neuroinflammatory response is. So it can be useful, but I think in these head-to-head studies that have used multiple biomarkers at the same time, including NFL and GFAP, it doesn't always add very much to the information you get from NFL.
Yeah, I agree with that. It has an interest in research because it's sort of targeting a slightly different component of the disease, but as a pure diagnostic classification tool, it tends to either underperform NFL or not add on top of NFL. So I do not use it in my clinical practice. But there might be use that could emerge over time, but currently this is not something that I prescribe on top of the other biomarkers we described.
Yeah, I just want to add two things. One, everything these guys just said about the diagnostic utility of these um, proteins, GFAP and NFL, I completely agree with. I'll point out that, there is another use that we think of for these proteins that is also being investigated, and we're not completely done thinking about it yet, which is tracking disease over time. So another potential value of these proteins is to see whether biologically the brain is responding to whatever treatment is being offered. So if NFL represents neurodegeneration and you're pretty confident that that's what's affecting people, and hopefully we start an effective treatment, we might be able to say that a reduction in the NFL suggests that the symptoms will respond soon too, for example. So there's a lot of work with these proteins, but not necessarily for diagnostic purposes.
Another example would be in trials. So there was a recent trial in genetic frontotemporal dementia with progranulin where it was part of the entry criterion. So patients who were mutation carriers, not yet clearly symptomatic, could be selected if their NFL was high, because we know from research that NFLs tend to spike up around the onset of symptoms. So there could be also a use for designs of clinical trials, which are particularly challenging in a rare disease, and so even more in genetic subtypes of FTD.
The other thing I was going to say, I realized I answered it in an answer to a query, but this is really important. So FTLD, that pathology that underlies all these FTD syndromes, is caused by one of three usually kinds of proteins accumulating, either tau, modified a little differently than in Alzheimer's disease, or TDP-43, or much more rarely a set of proteins called FET, which is an acronym that I can't even remember what it stands for. But anyway, Samuel say. So, but just to finish the comment, although the basic protein tau is the same, it's modified differently than in Alzheimer's disease, so that all of the current biomarkers for tau in Alzheimer's disease do not detect abnormal levels of FTD type tau, so they're not useful for FTD. We don't have any biomarkers currently to detect abnormal TDP-43. We're working on that. We don't have any biomarkers to detect the FET proteins that I mentioned either. We're also working on that. So that's important.
Yeah, and I think what I'm hearing from all of you is that, the current biomarkers that are out there are an additional data point, and I think we talked about this a little bit in our conversation. They can't take away from a good clinical assessment good health history imaging, but they may help aid in trying to better understand what the disease process is and what's happening there, which is very helpful. So with that being said, you were all very excited to talk about what we do see happening on the horizon and what you're hopeful for in the coming years. A lot of money has been put into biomarker research and in the FTD space. So what do you see as promising or evolving in FTD biomarkers, and what should we be keeping our eye out for and watching?
I mean, I can talk a little bit, and I think just as Howie mentioned, right, and Esther, you in introduction, FTD is a heterogeneous condition, and that clinical syndrome of FTD underneath the hood, when you look at the brain, is caused by several different pathologies. And I am really excited about the biomarkers that are coming out that can allow us to distinguish among these subtypes because I don't just, ideally, we wouldn't just be treating the symptoms of the clinical manifestations, we would be treating those problems. But we need a way to find them or identify them before somebody uh, comes to pathology, right? And so there are emerging biomarkers now, some of which are in serum, right? So extracellular vesicles and TDP-43 is something that there's been a lot of movement on and has a lot of promise. Some of the imaging biomarkers are really exciting too. I think I've heard about a PET tracer or more than one for TDP-43 that may start to, has been used in the research setting again, but I think it needs some real world validation. That's going to be the first step that sure it will help with diagnosis, but in my mind, stratifying people, identifying the camps that they belong in, and allowing us to direct therapies specifically against those camps is the most exciting and promising avenue.
Yeah. Well, I mean, we haven't mentioned a couple of biomarkers we use. Well, Simone mentioned one quite regularly, which is brain imaging. I'll note that for all, well, at least for the progressive aphasias and for BVFTD, those syndromes, that imaging is an important part of the criteria and diagnostic assessment. And um, Probably MRI is the preferred method for all those, and FDG PET can be useful sometimes as an adjunct. Um, uh, and uh, Essentially the reason those things are incorporated into the diagnosis is, I think we'll get to this more, people can have mild symptoms in the language domain that overlap with aging and other things. And people can have mild symptoms or even not so mild symptoms in the social and emotional realm that overlap with, non-neurological psychiatric disorders. Non-neurological in quotes, because anyway, they're still in the brain, but they're considered a separate field. That said, one way to feel more confident that the symptoms are due to a neurodegenerative disease is the presence of enough atrophy or hypometabolism in the regions that you would expect, like the frontal or temporal lobes, for example. So that's an important tool. And a lot of the tools we're talking about are to add specificity and early detection to those tools would be our goals, I think. Um, Somebody asked along the way for people with granulin mutations, what tools are being used to predict age of onset. And I'll generalize that to say, well, for anybody who who has an FTD associated mutation that puts them at high risk for FTD, this is an important question. And the answer right now is MRI is one of the tools we're using. NFL, we're trying to figure out how that adds to MRI. And GFAP is being investigated in those models to see if it's helpful or not. There are some other proteins that got mentioned along in the questions too, like neuronal pentraxin. There's some very sophisticated questions here, which is a protein that relates to the health of synapses, and other related proteins. I forgot what else was in the question. Oh, uh, PET scans detecting, synaptic health. All of these kinds of measurements, even though they may not be specific, because they relate to brain health, in a context like where somebody's at high risk, these all are being considered in the armamentarium of markers for predicting whether somebody is starting to get to a point where they're developing symptoms.
I agree
No,
that,
MRI. Sorry, stop. Go
oh,
ahead.
no, I agree that's an important and exciting area of research. In particular, now there's these large consortiums that have been gathering data on genetic and sporadic FTD for many years now. So we're starting to have larger data sets with people who we have followed up until conversion to the symptomatic phase. So this is starting to allow integrative approaches with things like machine learnings or various types of artificial intelligence approach to merge the complex data sets, integrating MRI signals and blood signals and various other things to predict conversion. Because for people who might not be as familiar in genetic FTD, you have these mutation carriers, and we know that they're almost certain to get the disease at some point in their life, but this can vary widely from age late 30s to late 70s. And so, if we're going to do research with interventions like medications, and there's a lot of them that are being developed for various genetic mutations, it will be crucial to be able to include people in trials who are either just converted or at high risk of conversion to be able to test if the drugs are effective or not.
Yeah. So thinking about all of this and where we're at and where we're going in the future and what we hope to see, is there anything that you would want those who are watching this webinar today? Is there one piece of thought or advice you want to leave them with before we maybe answer a question or two if we have time?
Well, one thing we haven't quite included in biomarkers, we don't usually think of it as biomarkers, but I want to reinforce the importance of genetic testing,
Mm.
particularly in behavioral FTD, even in patients that do not have a significant family history. We do find mutations, particularly C9orf and progranulin, in a non-negligible percent of the population. So, and more, we recommend genetic testing for most patients with young age FTD. It's very important to give accurate diagnosis, prognostic to family, do family counseling, but also there's a lot of these medications and gene therapies that are being tested for progranulin mutations, a little bit for C9. And it is very important that we identify these patients who could benefit from these research interventions, both for them, but also for the development of these treatments.
Yeah, I think
Yeah, go ahead.
oh, I was just very briefly, I think one of the best sessions I've heard on biomarkers came from Michael Benatar at the University of Miami. And there's so many different types of biomarkers. I think we often overlook the fact that genetics it's called a trait biomarker, right? It's just something that you have all the time versus a state biomarker, which is what we tend to focus on, right? If we measure it, does it tell us a change in the state? And genetics are incredibly useful. And just like Simone said, all the trials focus on genetics because we can tell the pathologic subtype based on the genetics, and we know what we're going after. If we had those biomarkers for the pathology, we would see more. I believe we would see more treatments being applied to more people with otherwise apparently sporadic disease.
Yeah, I'm looking at the questions, and there's so many great questions. I'm sorry we won't get to all of them. Esther, you can tell me if there's a way we'll get to them offline. But there's a couple that I think we kind of addressed, but I want to come back to because it's really important. Two people asked a related question of sort of, can we think of some of these biomarkers as something we would use like a wellness check, like which to me, and the way we use tumor biomarkers, and I think it's a very tempting idea. And I think the answer is it's not what's recommended now. And if you think about it, it's a complex question. Um, uh, and the reason is because, if somebody's 70 and you decide you're going to get the Alzheimer's biomarkers, why are you ordering them, right? If the person doesn't have any symptoms. Right now, our current science says we should not treat people with anti-amyloid treatments who have no symptoms because they may never get symptoms. So now you have to be prepared for a discussion. I'm getting this blood test, but if we find a positive result, you as a patient have to be prepared that, maybe it doesn't mean anything. And so on the or let's take another scenario where somebody has very mild symptoms and you decide, well, I'm not even going to ask any more questions. They could be Alzheimer's. I'm just going to get the Alzheimer's biomarker. Now you're in a situation where you still have to ask a lot more questions, or somebody has to. And some of those questions revolve around, do they have sleep apnea? Do they have mood disorder that may be causing the symptoms, even though the blood test is elevated? So, what you have accomplished by ordering that biomarker really early is sort of putting on the radar that they may be, you might want to get them to see a neurologist or a psychiatrist, depending, faster, and that they may be eligible for this treatment. But there's a lot of, forks in that road going forward that may mean that's not what's going to happen. And so that's why we keep saying, the best way to use these biomarkers now is in the context of a full evaluation. And it ends up not doing that much for the patient to order the biomarker very early before you know the full clinical context of what you're doing. I think this is a really good question. And the field may evolve, so that the recommendation changes about the order of things. But I don't think we're ever going to get, it'll be a long time before this full clinical assessment that we're talking about, which basically rests on a lot of questions and a good physical exam and basic imaging like MRI. Um, it's going to be a while before that becomes secondary, and the biomarkers tell the whole story.
I can take maybe I was looking at the questions while how was talking. There are a couple that are related. There's one that is coming back about the fact that p-tau 217 is more correlated with amyloid positivity than tau positivity on the PET tracer. So it is correct. So even though the name's a bit counterintuitive, p-tau 217 is more a marker of amyloid positivity. Whereas the tau positivity on the PET scan comes a little bit later in the disease. And so if you wanted to be 100% sure that there's tau positivity, you would need a PET scan with the tau tracer. And someone also asked about the distinction with frontal Alzheimer's. So clinically, there's some subtle indications. So usually the frontal Alzheimer's are a little bit older, have a bit more memory impairment. In my experience, have just a touch more insight that they have an illness as opposed to this like extremely blunt unawareness of pure frontal FTD. But again, that's a very good example of where biomarkers are essential because we can have our intuitions when we see someone that is probably more frontal AD than behavioral FTD, but you would need the amyloid biomarkers to be certain. And again, you're not excluding that someone could have FTD and positive amyloid in the brain as co-pathology.
Simone, I saw a question I wanted you to answer. And I think it sort of there's this one, if there are behavior changes and OCD-like symptoms that appear in the 40s or 50s, and MRI shows no shrinkage and the MoCA is normal, uh, to finish the question, is it just not visible yet, the changes, or could it be a psychiatric condition and late in life? And I guess I'm opening that up to sort of say, how do you think about,
Yep.
that differentiation and how to move toward some confidence in clinical practice?
Yeah. So Sammy said something important at the beginning, which is that common illnesses will have some unusual presentations, but will still be encountered quite regularly because they're common diseases. So, in general, a disease like OCD, psychosis would generally start in late adolescence, early adulthood. So when we see that emerging in someone above 40, 45, 50, there has to be the red flag. Could this be the initial manifestation of neurodegeneration? Now, that said, it could still entirely be primarily psychiatric illnesses, and probably in most cases, it is. So when you see a late onset psychiatric phenotype, there has to be some level of investigations, both in terms of questionnaire. You're going to ask if there's family history. If you hear family history of ALS, FTD, early onset dementia, then the level of testing will increase. You're worried about the possibility of neurodegenerative illnesses. You're going to do cognitive testing, you will do brain imaging. Now, in a situation like this where you have symptoms, you don't have the full profile, brain imaging is normal, then you would enter a phase of more longitudinal follow-up. And there is a point where if it is FTD, there will be hypometabolism, there will be shrinking, there will be cognitive decline. So if you see stability over time, by default, you can conclude that it's primarily psychiatric. It is one of the case examples potentially for NFL. If you do a serum NFL in a case like this and it's extremely high, then your likelihood that it's FTLD pathology increases.
That's a big question we get from the community very often. So thank you for answering that so well. Really, thank you to all three of you for today's presentation. I think we actually could probably sit here and talk about this much longer. I'm a little sad that we're done, but do you have another question you want to answer, Howie? Go ahead. We can
Well,
go a minute
you
over.
just addressed, you brought up the thing I really want to address, which is, these questions were great, and many of them reflect the fact that these cases are hard, right? And that you hear some things that you're not sure, and you may even get a neurologist or another expert in the community who gives an opinion that you're not sure is reflective of what you really think. And sometimes you may be right. And so the question is, what are your resources to do that, to go a little farther? And so I'll just point out a few things. A lot of states have Alzheimer's disease research centers in the US. That these are all places that study neurodegenerative disease, and some are more expert in FTD than others, but they all know a lot about, both typical and atypical neurodegeneration. I think they're often great resources just for asking an opinion. Can I ask, can I just talk to somebody or get an email from some expert? Sammy works at one, I work at another. In Canada, Simone works at a similar kind of place. Then there's resources like AFTD, which I know that they can both answer some questions, even at a professional level, but certainly direct you to people like us for those kinds of answers. I've had questions like that in the past. And lastly, there are these programs like Project Echo for the primary care folks that have been used in many different contexts, different specialties. And there's a growing number of Project Echo for dementia programs that you could join, where you could really present a case to a few experts about what do you think about this case and how should I manage this. And I think because in the end, the devil's always in the details of an individual case as to whether probably you know what you need to know or whether you push farther. So you should remember there's all those resources that actually can listen to all the details of the case with you and do their best to figure it out beyond these general rules that we're talking about.
I think that was a great way to end, Howie, and it's so true. There are experts around the country, throughout the world, who are working in FTD in other countries. There's GenFi, which is a great collaboration of experts working in the space, as well as the All FTD Network, as well as the ADRCs and the many programs out there. AFTD lists a lot of them on our website. But they really do offer the ability to help you kind of sort through these things, and can bring an expert perspective to the questions that you have. So thank you to everyone who is here today, and for our three wonderful panelists. I really have appreciated you coming and sharing your expertise and knowledge back to the community today. Unfortunately, we're not going to be able to address everyone's questions here today, but you are always welcome to reach out to us on the AFTD helpline. This concludes our webinar. Thank you for joining us. Please let us know if you have any comments or questions about today's presentation. And if you have any further questions about FTD, you can contact the AFTD helpline using the information on the screen. You'll look for an email that'll come to you on Tuesday with the directions to apply for your CMEs and CEUs. And with that being said, thank you and have a wonderful day.